Hello. All right, got it. Hi. So this is a CTI technical review, and we're going to be try to cover each and every component of the methodology that HSCRC uses to not only identify the CTI population for a given CTI definition, but also then calculate the episode costs, calculate the target price, and then each of the steps after that to get us to the final reconciliation payment. So this can be quite complex. So there's a lot of steps to get through. So I would take it that you already seen the slides that we sent out earlier, and they're probably a bit intimidating because they're quite dense, and this is only meant to be a 45-minute presentation. So obviously we're not going to cover every single detail on every slide, but the slides were meant to be as a good reference or a source of reference for you to take and apply to your own data to not only understand the steps that we take, but also possibly replicate or our results and just get a better understanding of things in real time as they go along, or to predict if you're setting up a definition or what have you. So today we're going to be so first we'll identify the CT population, and we'll be focusing specifically as for an example on the thematic area of care transitions for inpatient discharges. We'll go over the data that's required, provide an example or a hypothetical CTI, and summarize the criteria. We'll revisit the criteria that's available, which you might all be familiar with, as well as the specific steps we took. And then we'll do the same for episode costs and walk through how to calculate the target price and reconciliation payment. Okay. So let's start with the data source first. So the CTI episodes are structured by the HSCRC using what we refer to as the CCLF data, which is or officially the Maryland All-Payer Model Claim and Claim Line Feed data. So this is the universe of Medicare final action claims for all Part A and Part B services that are received by Maryland residents, regardless of whether that service was in-state or out-of-state. These data exclude non-Maryland residents. They are fee-for-service claims only, so they do not include Medicare Advantaged enrollees, and then we also exclude from the CTIs ESRD patients, which we'll discuss. And again, the claims in the CCLF data are all are all final action, paid, not denied, but they also exclude the SAMHSA claims of Substance Abuse and Mental Health and Service Association. All right, so the data sets, we use the whole gambit of file types available in the Medicare claims for parts A and B, and also including the demographic and enrollment to apply our criteria and identify the population. So that's inpatient, outpatient, Part B carrier claims, DME claims, hospice claims, skilled nursing facility claims, and home health agency claims. And so the claims will need to span the entire target period. So the baseline periods, the performance periods are Maryland fiscal year, spanning from July 1st of the previous year to June 30th of the given fiscal year. And also to create these CTIs, one of the criteria is to look back. And so so you'll need claims that spanned up to, maybe depending on the criteria specified, up to a year prior to the Maryland fiscal year that's targeted. And also included in the data are supplemental files. So Chris develops a series of files that supplement the raw CCLF data, as we would refer to it, and facilitate the identification of subpopulations, particularly relevant to the certain programs and their quality measures. And all of these files are derived directly from the CCLF data. Some of the files are based on proprietary or non-proprietary algorithms, and other files that simply provide a shortcut to commonly used data elements. So the files that are pertinent here to the CTI populations are the DRG details files, which are used to identify CTI populations based on the diagnostic criteria recorded on inpatient discharge claims. The address files, which provide each beneficiary's complete residential history and are used to identify CTI populations based on geographic criteria. You'll need the taxonomy crosswalk, which allows analysts to quickly identify the type of provider that's associated with each NPI number that's found in the CCLF data, as well as the first PAC file, which uses claims for institutional post-acute care and home health agencies to identify the first PAC setting that a patient was admitted to after they were discharged from the hospital. And these are based on MAID's algorithms for first post-acute setting after hospital discharge. That's also used in other programs. So, all right, so now that we've discussed what data are needed, we'll quickly review the general and CTI specific criteria that are used to identify any given CTI population. These general criteria are not optional. And the first three here are meant to ensure that we can identify every patient's complete history of medical encounters, as well as accurately calculate their total care expenditures during an episode. The final two pertaining to ESRD patients and deaths, those are intended to avoid including patients with extraordinary cost profiles. And so while these criteria here pertain to all CTI thematic areas, certain thematic areas will relax the ESRD or the death-related criteria based on the context. For example, palliative care CTIs by definition will not exclude patients whose episodes ended upon their death. So the general criteria are ensure that the individuals are Maryland residents throughout the entire episode period, and a look back period if it applies. Also ensure that they are that they are enrolled in both Medicare Parts A and B enrollment, and that Medicare is their primary payer. And we'll get to the logic on how to identify these. Okay, so next, we'll move to the optional criteria, and those are the criteria that CTI participants can choose to use to identify their specific patient populations on which they plan to implement an intervention. If the participant chooses, so I'll note here that if the participants choose not to specify a certain type of criteria here of these optional ones to identify their patient populations in their intake templates, then by default, the HSCRC's programs will simply just skip over those restrictions. So they won't be applied, and there's no really baseline or starting point regarding those criteria. And I'll also note the criteria for the care transition CTIs, they're common across most of the CTI thematic areas, but each thematic area's set of criteria are going to be tailored based on context again, and so might include and so other thematic areas might include a CTI specific criteria that isn't discussed here, or they might exclude one or more of these that are discussed here. And also note that in these next three slides, we'll talk about these criteria. We provide an example column. So altogether, the example criteria here are going to describe a hypothetical CTI definition under the care transitions thematic area. And then we'll use that hypothetical CTI in the subsequent slides to provide some examples for how the volume of potential episodes rapidly shrinks as we apply each inclusion and exclusion criteria in our programs. Okay, so the first three optional criteria here for the care transition CTIs are geographic service area, which is simply limits the patient population based on 5-digit zip codes in which the patients reside at the time of a hospital discharge that triggers an episode. In our example here, we used 20 Maryland zip codes to define that area for the hypothetical CTI. There's also primary diagnosis or APR, DRG, and severity of illness, and uh, uh, risk of mortality codes. So um, the primary diagnosis, when we're referring to the principal or the primary diagnosis directly on the hospital discharge claim, which ICD-10 code. And then most of you are probably familiar with the APR-DRG, the SOI, or the ROM codes that are also affiliated with inpatient claims. Chronic conditions. There is when we say chronic conditions, we're referring to the ability to exclude or include patients that have been diagnosed with with any of the set of 27 CCW chronic conditions for what based on their claims history. The algorithms to compute those are CCW algorithms and are available online. There's a link here if you want to review those. Fortunately, if you were to play with the data, the CCLF data, you wouldn't have to code those up yourselves either because those flags are in the data and can easily be used. The options there in the chronic conditions is you can specify a specific set of chronic conditions, or you can specify a certain number of any of the chronic conditions with which they might have, which they're had to have been diagnosed. Okay. All right, so continuing with the optional criteria, one of the criteria that you can specify is prior utilization, which is requiring that individuals just specifying a time window with which to quote unquote look back from the inpatient hospital discharge that's triggering the episode, and look back for some combination or individual and some number of inpatient hospital stays, outpatient observation stays, or ED visits. You can specify a threshold greater than 0. The higher that threshold is, obviously, the lower the episode volume will be. And then there's look back, which could be specified. And when we say look back, what we're doing, it's different than prior utilization, and that look back is specifying whether one or more, whether their patient had one or more particular medical encounters in a given specified look back period or time window from the date that the episode was triggered. Those medical encounters can consist of a primary care visit, home health care, stay at a skilled nursing facility, or acute care hospital, assisted living, or psychiatric care facility. And then the look forward. The quote unquote look forward is simply looking at specifying and excluding or including patients based on where they were, their first setting after their hospital discharge. And by first setting, and so their first setting is defined using the MAID algorithm. And in general, that means, so you can specify LTECs or IRFs, or basically institutional post-acute care. They're classified as being discharged to institutional post-acute care if they were admitted to an LTEC or an IRF within 2 days of the hospital discharge, with no other post-acute care provider claim for a post-acute care provider in between those 2 days. SNF admissions are determined similarly, but with 3 days where admission is within 3 days of the hospital discharge. And then we look forward up to 14 days for the start of home health care for an individual with no post-acute care in between the discharge and the start of health care. Okay. And then lastly, with regards to criteria, there or options, there's other options that participants can specify for each CTI. So one is the length of the CTI intervention, and this serves, and so the length of time between when the episode is triggered and when the episode ends based on this episode length is what we're referring to when we say episode window. And that episode window typically begins on discharge from the hospital. The default option there is 90 days. So if another alternative is not specified, we assume that all the episodes will have a 90-day window with which to calculate total episode costs. And then, yeah, and those total episode costs include all Medicare Parts A and B costs. Another option is that the participant can specify whether to include or exclude the costs of the hospital's stay that triggered the episode. If they do choose to include it, they are actually including any Medicare expenditures that occurred between the day of admission and the day of discharge, regardless of whether the claim is actually linked or tied to to an inpatient claim for that hospitalization. So the default there, if not otherwise specified, is to include those costs in the total costs of an episode. And then, of course, every CTI participant can choose the particular baseline period with which they want to be compared against for reconciliation purposes. These are Maryland fiscal years. I believe we had 2016, 17, 18, and 19 to choose from. So in this example here, we're looking at data from fiscal year 2018. Okay. All right. So like I said, we're going to be focusing here on an example for care transition CTIs. Care transition CTIs are what we call episode-based CTIs. And as our palliative care and the emergency care CTIs. The primary care and community-based care thematic areas allow participants to implement either an episode-based CTI or a panel-based CTI. So by saying episode-based CTIs are ones where they are triggered by a particular type of medical encounter with a specific patient profile based on the optional criteria. Those episodes are then attributed to the providers involved in that medical encounter, and these episodes can begin on any date during the performance year and end after a specified length of time. Whereas the panel-based CTIs, those have a CTI population based on selected from patients with a specific profile, again, as in those optional criteria, and they're attributed to the providers based on their history of medical encounters between them. For example, to define the primary care panel CTI, or they reside in a specific provider service area at the beginning of the target period. And with panel-based CTIs, patients are attributed to a provider and followed, and their costs are calculated for the full performance year, typically. Now, just because we've been referring to episode-based CTIs, panel-based CTIs doesn't mean that future CTI thematic areas could include some hybrid approach of the two. For example, where a patient might be attributed due to a specific medical encounter at any time during the year, but then they're followed until the end of that given target period. Might be an example of where you would have sort of a hybrid approach to a CTI. But as of now, we have purely episode-based and purely panel-based CTIs in the program. So, all right, so for the rest of these slides, again, they're quite dense. We intended this to be a resource for you to take home and apply to your own data. So what we're going to describe here is, the data files, the variables, the logic necessary to apply each of those inclusion and exclusion criteria that I just went over. They're all in here. If you get a chance to review the logic or something's not quite making sense, please feel free to follow up with questions, and we'll be happy to answer those. But for the rest of this presentation, I'm going to kind of go through and just highlight certain points to make sure that we have time for the stuff that may or may not be more interesting to you in the latter couple of sections in terms of calculating the target price and reconciliation and what have you. So I'll note that the order in which these criteria are included here in these slides, they are the order that we suggest to limit the computing time it would take, the processing time that it would take to identify a final set of episodes from these very large Medicare claims databases, but they could be implemented in any order. And on each slide, we'll provide examples of the output that you might expect after implementing each logical step. Okay. And then also note, we're also preparing a document that accompanies these slides, so that that contains the same information presented here, and we'll produce those the same type of documents for a panel-based CTI or probably each thematic area. So more to come after this presentation. All right, so so this is the first step, is to identify inpatient discharges from participating facilities. Really quick here, each of these subsequent slides are going to provide a description of the logical, what each logical step does. It'll provide in what particular types of files that this step needs and the particular variables from those files, and then it also provides just some simple, very basic pseudocode / logic that should be, implemented in the computer programs to apply these restrictions. So each step in the logic also provides a box to the right that you'll notice describing the episode volume that we started with before the particular exclusion criteria were applied, and then after the exclusions were applied, based on our hypothetical CTI definitions. And those numbers are going to provide a sense of how impactful each of these criteria can be on the size of a given CTI definition. And it'll provide a general sense of how small a CTI could become after all the potential criteria are applied. Okay. So in this first step here, we use CCLF data to filter the claims to claims with a date of service in this the designated baseline period. And for the purposes of this example, we chose a particular provider, and it amounted to so out of 233,000 inpatient discharges that could have potentially triggered a care transition CTI, we ended up with 7,600 to start with. And so those, yeah, okay. So, all right. So the next step here is that we're going to want to apply for each hospital discharge to find an episode begin date, episode end date, or as we refer to it, episode window, and if necessary, then define a look back period. And so you're going to want to define these dates ahead of time before applying any subsequent criteria, because they're all going to be used throughout the logical code that's used to apply the criteria. I will note that there's some crossed out steps here. 4 and 5 are typos that were accidentally left in the first draft of these slides, and they aren't applicable. We caught those on our when I was preparing for this, and even if they were applicable, they also had a typo in them to begin with. So we'll fix that mistake and resend this slide deck with some other materials sometime next week again. So if the default option is chosen, and the participant chooses to include the costs of triggering inpatient hospitalization into the total episode costs, then the episode begin date is going to be the admission date. And if the cost hospitalizations aren't specified, then the episode begin date is going to be the hospital discharge date. Regardless of whether the costs of the triggering hospital stay are included, the episode end date is the discharge date plus the specified episode length, and minus 1 day to include that day of discharge in the episode window. The look back is also particularly specified for the type of utilization for which we're looking back. It's specified by the participant, and that is and so the look back window is defined as the maximum length of time that the participant specifies to look back for any particular type of utilization. And so, for instance, if it's specified for a 1-year look back for prior hospitalizations and a 6-month look back for prior ED visits, then the look back period for each episode will be 365 days. And you can determine those dates up front before moving to the next criteria. I'll note, so the next steps, we apply the general criteria that we went over, making sure that the beneficiary is a Maryland resident throughout the episode window, that we just defined, that they're enrolled in parts A and B, and that they did not die during, the episode did not end because of death, and make sure that all claims within that episode window are primarily paid by Medicare. And end-stage renal disease, you look at the whole calendar year in which for the performance year to determine whether they have ESRD status, and they would be excluded. So by applying these here on the right, we see starting with 7,600 hospitalizations for that particular provider. Applying these restrictions already limited down to about 20% of those discharges, and down to about 6,059. You'll also notice some yellow text and numbers here. We noticed we had a misplaced slide in the grand scheme of things, referring on limiting episode overlaps, which I moved down later in the slide deck. So let's presume that we applied all the restrictions and we're starting with on the slide here at 5,652. Again, that will be updated on updated slides. So the geographic service area, I'm just going to provide a high level. So this is, again, including individuals that are residing in a particular set of zip codes specified by the participant at the time that the episode is triggered, at the time of their inpatient hospitalizations. You could use the supplemental address file here. It contains the zip code where each beneficiary resides and a span of date that's tied to each zip code. So by linking those dates and zip code to the service dates on the triggering hospital stays, you can include and exclude the correct individuals. The next one's fairly quickly to implement as well. This is basically selecting to identify hospital discharges with specific list of primary diagnoses codes. And that's based on the principal or the primary diagnosis, which is right on the claim. So you would just set the excluding criteria if that is specified, and exclude any primary diagnoses that are not in any hospitalizations with primary diagnoses that are not in the specified list. As an alternative to primary diagnosis or as a complement, you could also use APR, DRG, and SOI. Those are not provided directly in the claims, but thankfully Chris provides DRG details files, which you could merge onto each hospital claim using unique claim ID, and simply exclude those hospitalizations that aren't associated with the DRG code that is in the list of accepted DRG codes. Again, where was I? So after so geographic service area, after eliminating that, we're already down to 24% of the original 7,600. Sorry for going back and forth. So starting with that number, now that in our hypothetical scenario, they specified APR DRG codes that match a specific list. That is narrowed down to 468. So now we're already dealing with only 6.2% of those 7,600 inpatient discharges that we initially found for that provider during the baseline period. All right, so chronic conditions, also fairly straightforward application. There are 27 chronic condition flags in the demographics enrollment file that can be linked to the beneficiary in each episode according to their beneficiary ID. Their MBI number is what it's called in the claims. These flags include both a mid-year and an end-year flag for each condition. They're used to and so both flags are defined using the same predefined reference or look back periods, which CCW defines. For example, the COPD flag uses a 1-year reference period, while the diabetes flag uses a 2-year reference period. The only difference between these two flags is it's the point in time in which they look back from, right? So episodes triggered between July and December of a given Maryland fiscal year will use the mid-year condition flags to identify the patients with a specific set of conditions or a specific number of those 27 chronic conditions. And then all other episodes from January through June will use the end year flag for the previous calendar year. So we're just as an indicator for diagnoses, chronic conditions that are diagnosed. After applying this into our hypothetical scenario, we went from 468 down to 112, and now our list of episodes is representing 1.5% of the 7,600 original inpatient discharges. All right, so now we have prior utilization, where the participant can specify prior use of acute care services as inclusion or exclusion criteria, where these acute care services include inpatient stays at short-term acute care hospitals, outpatient ED visits, or outpatient observation stays at a hospital. And each of the and in the next slide, we provide the logic for identifying each type of service according to, say, claim type code, or you could use and using the CCN, and matching the dates of service to the look back period for each of these. Okay, so just real quick, I want to highlight that we view any overlapping inpatient stays, ED visits, and observation stays as only one acute care event in order to double count in the counting one medical event in a patient's overall history, right? So we apply a hierarchy to define the single acute care event, what that single acute care event would count as. So first, we collapse the multiple claims from concurrent hospital stays, including hospital transfers, into one overall inpatient stay, using the earliest admission date and the latest discharge date. And then if an ED visit overlaps with an observation stay, we call it an observation stay. If an ED overlaps with a hospital stay, we call that a hospital stay. And then if observation stay overlaps with a hospital stay, we define that as just a single hospital stay as well. And so then after that hierarchy is applied, we compare the final number of events to the participant specified threshold. This slide here provides an example of that. So this poor patient had 2 outpatient ED visits during their look back period, 3 inpatient stays, and and a claim for an outpatient observation stay. After applying that hierarchy, though, dealing with the overlaps of these medical encounters, we end up with 1 outpatient ED visit and 2 inpatient stays with which to compare against the criteria or the threshold specified by the individual. So in this example, for instance, we first combine these 2 inpatient stays here, the second and third rows, because the admission date for the second was only within 1 day of the previous one. So now we have 1 inpatient stay with an admission date from February 1st and a discharge date from February 4th. Okay, and then this outpatient ED at the top didn't overlap with anything, so that stays. This ED visit here overlaps with the start of this inpatient stay, so we consider that an inpatient ED visit, and that is excluded. And this outpatient observation stay, the from date on that claim overlaps with the discharge date of the hospital inpatient claim, so we excluded that outpatient observation stay according to the hierarchy. So we end up with 3 events instead of 1, 2, 3, 4, 5, 6. Okay, so next we got the look back from previous medical encounters. And so when we say look back, we're looking back for at least 1 encounter of a specified type, including primary care, home health care, skilled nursing facility stay, short-term acute care hospital, or ED within a certain number of days that the participant specifies. There's no need for a hierarchy here. You could simply look for on the from and through dates and the service dates basically of those claims to see if they fall in with that window. There's no hierarchy here because, again, we're just looking for whether at least 1 of a certain type was had during a particular period. And again, we provide the logic here for identifying each one of those types of criteria and assessing whether it's in the episode window. Okay, and then the last criteria, sorry if I'm going really fast here, but yeah, these are quite dense. So the last criteria is the look forward criteria, quote unquote, look forward, or basically the first pack criteria. And this is fairly straightforward to implement because Chris has done all the hard work in providing you that first pack file with which you could link to the hospital discharge claims via the unique claim ID and identify whether the first pack setting meets the specified criteria or list provided by the participant. The options here, again, are inpatient, post-acute care, which is long-term care, hospital or an IRF, skilled nursing facility, home health care, or if none of the above, if the patient had none of those above at their first pack, then they're considered as discharged to the community. Okay. And so after applying all those criteria, we've whittled down the 7,600 inpatient claims for that provider to just 0.7% of those claims. So after we apply those criteria, that's basically our set of still potential CTI episodes, whereas the hospital discharge claim is referred to as the triggering event. But we still have to eliminate overlapping episodes to get to our final CTI count. So in terms of overlaps that are allowed are those of episodes or beneficiaries that are attributed to two different hospitals, even under the same CTI definition. Episode beneficiaries that are attributed to the same hospital's episode and panel-based CTIs, those are allowed. So if a patient is involved in more than one episode, one of them is episode-based, or more than one CTI, and one of them is episode-based and one of them is panel-based. Both of them are allowed to stay in the set of CTI episodes for that participant. Overlaps that are not allowed include episodes that trigger multiple CTI definitions for the same hospital. So only one CTI is allowed. And then beneficiaries, and we also exclude beneficiaries that are attributed to more than one of the same hospital's panel-based CTIs, right? Okay. So dealing with overlapping episodes within a CTI definition, each patient is attributed to a provider CTI is only allowed to have one active episode on any given day. So this slide was moved down to the spots here, remember, because we realized that it was inaccurate to say that we eliminated overlapping episodes before we even applied the specific CTI criteria. So once all the criteria are allowed, then you assess the overlapping episodes and exclude those that are overlapping. So as a quick summary of the logic listed here, basically, we order all inpatient discharges for a given beneficiary chronologically, and then going in chronological order, we eliminate an episode that was triggered within the previous episode window. And once that's eliminated, any subsequent ones well, here's a good example. So if we had 3 episodes for the same patient for the same CTI, we will eliminate this second episode because the begin date and episode date overlap. So this one was triggered during the previous one's episode window. Once that one is removed, this third episode here will remain in, because once this one is removed, this one no longer overlaps with a previous CTI's episode window, right? Okay. All right, and then lastly, you'll want to eliminate episodes that overlap other CTI definitions. So HSCRC applies a CTI hierarchy to episode-based overlaps of CTIs within the same hospital. It prioritizes CTIs from the lowest to the highest episode volumes in order to ensure that the smaller CTIs are attributed as many episodes as possible. And so if a single event could trigger multiple CTI definitions, then the CTI definition with the lowest volume in the hierarchy is retained and the others are excluded. Beneficiaries who qualify to be attributed to more than one panel-based CTI, they're allowed to be attributed to only one of those panel-based CTIs. And we could circumvent this whole hierarchy if the participant specifies their own hierarchy to determine that precedence between overlapping CTIs. Okay, with that, I'm going to switch it over to Nate. That's about a 40 minutes in, so hopefully we have enough time, and he's not too rushed. And he's going to talk about how to calculate episode costs. Are you there, Nate?
Can you hear me?
Yes.
There we go. Sorry about that. So everything that we're going to go through as we describe how to calculate the episode cost is really in service to two sets of goals. One, from a policy perspective, we want to make sure that the evaluation of episode payments is equitable, that we are accurately measuring as close to the total cost of care as we can for these beneficiaries. And then from an operational standpoint, in response to a lot of feedback during development, we want to be presenting this data in as timely a fashion to participants as possible, so you can make use of it during the program year. So both of those kind of feed into the discussion we're going to have over the next 10 slides. So to start off, there are a small number of costs, and when we say costs, we mean payments here. All of this is ultimately based on payments from Medicare to providers. We're not talking about actual hospital costs here, so when I say costs, we'll use those interchangeably. We do exclude a small number of payment types, and these are derived from criteria that CMS applies to other programs. They are generally recognized as costs that are worth excluding. However, I will say that while from a policy and logical standpoint, all of these are implemented, we may or may not be able to identify and exclude all of them. So if you're actually diving into the claims, for example, CMS does pre-processing on the CCLF data, and for example, medical device pass-through payments are not always indicated as such on the claims. So if the data that we get from CMS doesn't identify those, we can't exclude them. But if they are identified per these criteria, we will drop these. As a general rule, these make up a very small proportion of the total cost of care, but we do want to note them because it is built into the logic. Next slide. So generally speaking, when we talk about total episode costs, we are talking about total cost of care for these Medicare fee-for-service beneficiaries. So what we're going to do is go through, and once we've identified the episode and the episode window for a beneficiary, we collect all of the claims that have dates of service within that episode window. And very simply, we're going to be adding up all of the actual paid amounts on those claims with a couple of caveats, and we'll go through those. The first caveat is in service to that notion of providing data in a timely fashion. It typically takes claims anywhere from 6 to 12 months to complete, in the sense that all of the adjustments and adjudications and reversals come in from the claims processor. And so for the CTI program, what we do is the HSCRC has conducted a lot of research to understand statistically how complete claims are at a given point in time. We take 3 months of run out on each claim, at which point most claims statistically are on the order of 90 to 95% complete. We freeze those claims at 3 months of run out, and then we use a completion factor to scale those payments up to 100%. And that way we can always get complete payment data to you within 3 months of the date of service on a claim, rather than having to wait a whole year. Now, all of that is done on the base input data set before you see it. So all of the numbers that are displayed ultimately in reports, in the CTI, all of these payment analysis steps have already been applied. So when you look at them in the CTP, you can assume that those numbers are comparable. Next slide, please. So we said that we aggregate all of the claims that have dates of service that overlie the episode window. If a claim spans the end date, for example, of an episode, we do prorate those claim payments. So we're not going to apply the entire amount of that claim to the episode. Instead, we're going to take the portion of it that we can attribute to the episode and isolate that. And that happens in two different ways, depending on the claim type. Some claim types are a simple per diem method. So sniff stays are a good example of that. If you have a 10-day sniff claim, 5 days are within the episode, 5 days are outside the episode. We'll only take the payments associated with the 5 days within the episode. For other types of claim, we use a length of stay proration method that, as described here, prorates all of the non-outlier payments by basically doing a comparison to the mean length of stay for that DRG for a given year to the amount that is within the episode period and prorate it accordingly. Outlier payments are always prorated just on a per diem basis. Next slide. So when you're going through later, this slide basically summarizes how we prorate the claims by claim type. Again, it's the most appropriate proration method per, and you'll see that some of them aren't prorated, and those are typically for claims that only occur on a single day. So the claim is either within or without the episode, and there's no need to prorate. Or the costs can't be accrued on a prorated basis. Next slide. So moving forward with these next few steps, I do want to say it can be very difficult to replicate these costs using the raw CCLF data. So when you're going through, if you have access to the raw CCLF, if you add up the total payment amounts, you're likely to see a mismatch. To a large extent, that's because of the policies that the HSCRC has implemented to deal with the effects of the GBR on episode evaluation. And we'll go through how that works in just a second here. But basically, at a high level, what we're doing is standardizing the amounts on all regulated payments. So all regulated inpatient and outpatient payments for Maryland services, so that fluctuation in the GBR aren't causing any sort of adverse or unintended beneficial impact on your stays. So for example, if a hospital is running low against its global budget at the beginning of the year, and you have a discharge for a knee replacement that costs, say, $5,000, and that's below your run rate, and then you have the exact same type of discharge, same services applied later in the year when you're running hot, maybe under the GBR, that same stay would get charged for $7,000, a different amount. What we do when we standardize is we take all of the equivalent claims and make sure that they're evaluated on a same basis, so that stay in February costs effectively the same as that stay in September, even if the actual GBR charges for those stays differed in the actual payment amounts. And the CCLF file does not contain these standardized amounts. The CCLF files only contain the actual paid, which will reflect those GBR variances that we want to make sure that we neutralize. Next slide. So additionally, going back to servicing, that goal of making sure that all payment amounts for both evaluation and review are comparable, we do inflate all dollars to performance period dollars. And again, we do this before starting the episode analysis. So all of the outputs you see in the CTP, whether they are baseline or performance year, are always going to be in same year dollars based in the performance period. And we do those inflation adjustments in two different ways. All of the non-regulated payments are inflated using CMS prospective payment system market basket update factors. So those are the same market basket updates that CMS uses to inflate the actual PPS rates. They're available from CMS, and we'll go through an example of that on the next slide. Regulated payments get their own special handling, as we mentioned. Those are going to be inflated based on the HSCRC update factors. And then on top of these, we do make special adjustments to account for one-off policy events. We won't go into a lot of detail here because we don't have time. But for example, CMS noted that there were overpayments in the SNF prospective payment system starting in 2019. So we do adjust for that to make sure that participants aren't held accountable for it. Similarly, sequestration was suspended during the COVID-19 public health emergency, and we don't want to penalize providers for the extra payments that came through during that period. So we also neutralize that out when we're doing these evaluations. And we'll continue to make those adjustments as needed. And again, happy afterwards to address any questions that relate to those. Next slide. So for unregulated payments, essentially what we're going to do is accumulate the inflation factors inclusive of all policy adjustments that CMS implements by each prospective claim type. So if you're familiar with the market baskets, SNF has its own inflation schedule. Home health payments have their own inflation schedule. Non-Maryland inpatient facilities have their own inflation schedule. So each claim is going to get inflated from the baseline period to the performance period using that appropriate update schedule. Go to the next slide, please. So these are some really simple examples using the market basket updates for SNF and home health. And you can see essentially what we're just accruing is this percentage inflation factor that is generally on the order of 2 to 3% per year. It can be as low as 0.25% or as high as 3 or 4%, depending on what happened and what additional adjustments were made. But you can see we just accrue that over the time period from the baseline, which in this case is fiscal 17 inflating to fiscal 22. Accrue the inflation over each of those periods, and you'll see that the total claim payment total comes out to the top line amount that comes out, and across the entire episode, it'll be a mix of those inflation factors depending on the mix of services that got accrued into that episode. Next slide, please. Finally, for regulated payments, what we do is we implement that standardization that was described as a very first set. And basically, we use a CMS standardization for allowed amount method to do that, to make sure that we're equalizing out any payment variance that's due to policy effects. We then inflate that standardized amount using the HSCRC inflation schedule, and then apply a standardization ratio to bring those dollars back into line with the real total GBR payments for a given period. The standardization ratio is just equal to the actual paid amount divided by that standardized amount that we get. For the baseline periods, you're going to have a consistent standardization ratio that says, here's how many GBR dollars are paid out for a given hospital relative to what the calculated standardized amount is. And that way, if you look at the total payments that we end up evaluating, you get the correct dollar amount. But again, we've now eliminated all of the variation due to fluctuations in the GBR between the different comparison periods. Next slide, please. So this slide will just give kind of the simplified formula for that. And again, due to time, won't go into a lot more detail here, but you can use this to get the final inflated regulated claim payment amounts, which again, anywhere you see that in the CTP, those numbers have already gone through this process. You don't need to worry about GBR effects or inflation when you're trying to compare baseline numbers to performance period numbers in the CTP itself. Next slide.
All right. So we'll jump right into briefly discussing how we calculate the target price. So for each participant in a CTI thematic area, the target price is calculated as the predicted level of episode spending during the performance period. And that's going to be based on the participant's average episode spending during the selected baseline period, as well as their average HCC score among their attributed beneficiaries. And if the episode is triggered through an inpatient hospital stay, if the CTI thematic area is triggered by a hospital stay, and the CTI definition specifies including the cost of the inpatient stay when calculating the episode spending. The model also includes the average APR-DRG SOI weight among the attributed beneficiaries. So that's represented here by this equation. So in order to estimate the target price for each specific CTI definition, we use a statewide CCLF data from the baseline year. We identify all the episodes in that state that meet the criteria for each CTI definition, and then identify the hospitals that they are attributed to. So then we estimate this equation here that's in red at the episode level separately for each CTI definition. So we use this statewide data set in order to estimate the average association between the patient's HCC score and APR-DRG weights, which are captured here by these beta and these gamma parameters that are estimated. The alphas are fixed effects for, these represent vectors of fixed effects for each provider. So the alpha state here represents a series of fixed effects for each provider where the flag equals 1 if the beneficiary was discharged from the provider's hospital and it meets all of the CTI criteria except for, say, the geographic and zip code criteria, and therefore were not ended up being attributed. This component here was added after PY1 because we noted that the predicted target prices were not as precise as they should have been without explicitly adjusting for those cases where the patient was that provider's patient, but they were not officially attributed to the CTI. So the alpha attributed here is defined similarly, but it equals 1 for episodes where the patient meets all of the specified CTI criteria and would be attributed to that participant. So the estimated fixed effects here are the most important parts because for the episodes attributed to each hospital provider, alpha attributed represents the historical average baseline costs for that specific participant's attributed episodes, adjusting for patient risk scores. Okay. And as an additional note here, we do Windsorize the total episode cost prior to risk adjustment to reduce the effects of very expensive or inexpensive episodes on the results. This mode is and this model is only used to estimate target prices for episode-based CTIs, such as care transitions. For panel-based CTIs, the model is simpler in that there are only 2 alpha parameters for beneficiaries who meet all of the other criteria, but are not attributed to the provider's panel CTI. And then the alpha attributed is one fixed effects that captures those that are attributed to the specific CTI. Sorry, I went one slide too quick. So here, we're about out of time. Will this keep on going, Jessica?
Yep, you're good to go after. And for those that need to drop, this is being recorded and it will be posted in the learning system.
Okay. Yeah, sorry about the time. We're almost done. All right, so once we estimate these parameters for beta and gamma and the baseline, we can calculate any provider's attributed or any provider's CTI definition's target price by simply plugging in checking, basically. So we have the fixed effect for each particular CTI definition or provider, and then we would use the average HCC score for that provider's attributed episodes, and plug that into this equation with the pre-calculated beta and the gamma and alpha, and then we would also, and for those that include the those models that include the APR-DRG, we would calculate the average APR-DRG weight for all attributed beneficiaries for that CTI definition, and plug that into the model, and then by summing those up, calculating this equation, we would get the estimated target prices. Now, that we have a baseline target price, and then we have a revised target price, and the target prices are revised to account for, by the time of reconciliation, to account for changes in participants' average risk score between the baseline and the intervention periods. So So as an example here, we could see we provide the average risk score, and we use the estimated coefficients from the baseline period, and then the average APR-DRG weight for a given participant under the same CTI. We can just sum those together and we can calculate the target price. In the performance period, the average HCC, we adjust for changes in the risk scores of the attributed beneficiaries between the two periods by using an updated HCC score. These are prospective HCC scores that are calculated with prior 365 days of claims data. So this is an HCC score that is essentially updated by being calculated for all the particularly attributed beneficiaries using their last year of claims data. So we can see that lowered the average APDRG weight was roughly the same, and that led to a small change, relatively small change in the target price between the baseline and the performance period. This target price here is what will be included in the reconciliation, which we will turn to now, and Nate's going to take it back over and close this out.
Thanks. So one note here, again, with regards to kind of our policy versus operational goals, we do want to make sure that the final reconciliation is as accurate as possible, which means waiting until we're sure that we have 100% of the final data necessary to score the CTIs. And so on the operational side, we do update the CTP monthly with data as it comes in, but any data that you see with regards to target prices, payment totals, reconciliation before that final reconciliation should be considered preliminary. We know that especially early on during the performance period, as episodes are accruing, we know that the numbers can fluctuate quite a bit. So we do want to make sure that we're providing data as quickly as possible to participants for those who do want to take advantage of it. But we do caution about drawing too many conclusions about the preliminary data, again, especially early on, just knowing that it unfortunately takes a while for claims to make their way through the system and the final data to arrive at us so that we can process it. Next slide. So as most of you should be familiar with, there is a minimum savings rate that is required for CTIs in order to earn savings. This is essentially done to ensure that the state and CMS isn't paying out shared savings just on the so the minimum savings rate is set depending on the N that's included in your CTIs. A participant can have up to 2 different MSRs. You'll get 1 MSR for all of your episode-based CTIs. So we take the entire volume associated with those, accrue them to set 1 MSR for those, and then a second MSR if a hospital is participating in any panel-based CTIs. The reason for having these 2 is because we know that there are different levels of variation and different payment profiles for panel-based episodes versus episodic CTIs. And you see that reflected in the chart at the right. The savings rate is calculated as just your total episode costs as calculated previously, divided by your final target price times episode volume. Pretty intuitive, and you can see that as the volume on CTIs goes down, especially for the setting specific or episodic CTIs, the minimum savings rate does go up. And these are, again, just based on power calculations to determine how big of a difference we have to see to be confident that what we're seeing is genuine savings and not noise in the population. And you'll have a MSR set for each program year. So if your participating CTIs change from performance year to performance year, say you add another high volume CTI, your MSR will be updated for the subsequent performance year to reflect that. Next slide, please. So what we do is after we have all of the final CTI data, we're able to determine what the final MSR for the performance period is. We calculate your final target price and your final payment amounts and determine what the required savings threshold is. So for example, if your MSR is 5% and you have $1 million in total target price, that means the minimum savings threshold would be $50,000. And then we rank all of your CTIs according to the required savings and how that compares to your actual savings. The reason that we do this is we do want to give essentially credit for CTIs that significantly exceed the savings threshold, so that if you have CTIs that come close but don't quite cross it, you can use that accumulated excess savings to essentially get over the savings threshold for those that didn't quite make it. And we'll go through an example of this that'll hopefully clarify on the next slide. The only thing I want to clarify before we get to that is that the final reconciliation payments that are made via the MPA take into account both the savings that a participant accrued minus the statewide savings offset. So this is the budget neutral part of the program. The statewide savings offset simply takes all of the savings across the entire state, the entire program that exceeds the minimum savings rate, and then applies that as an offset to each hospital on the basis of its proportion of the GBR payments. And so it is possible in some situations, if you have a very small amount of savings at one hospital, but significant savings at other hospitals, that savings offset could exceed the shared savings of that given participant. And again, that'll display in the CTP along with the final reconciliation values. Next slide. So here we've got an example, and it's got a lot of CTIs just to make a point. This participant is participating in 7 CTIs, and you see that we've ordered them based on the difference between the actual savings and the required savings. So for that first CTI, the required savings was $189,000. The actual savings was $485,000. There was a lot of excess savings accrued to that CTI. We're going to bank that so that if we get to a CTI that doesn't quite hit that savings threshold, we can use that to bump it up over the total minimum savings threshold. And so we continue doing that. The second CTI only exceeded the required savings threshold by $17,000. The third one only exceeded the required savings threshold by $1,000. Up until now, we've still been accruing positive excess savings. When we get to the fourth CTI in the list, you can see that the required savings was $315,000, but the actual savings was only $292,000. So we missed our target by $23,000. In the right-hand side, though, we can see that we've accrued quite a bit of excess savings. And so we're essentially going to take $23,000 out of that accrued excess savings and apply it to the CTI so that you still get credit for the $292,000 that were earned, even though it didn't quite hit the savings threshold. The fifth CTI, we've got the same situation. We take the $40,000 of accrued savings by which the savings threshold was missed. We add that in, and the CTI is given credit. However, when we get to our sixth CTI, you can see that they missed the target price by a considerable amount, $494,000 in aggregate. This participant doesn't have enough accumulated excess savings to make up that difference. And so at this point, we stop the reconciliation process and go back to the cumulative savings from the last CTI, which you can see in the green there is $1,013,000. And that's what is going to be the ultimate shared savings that's recognized for this particular participant. Those last two CTIs, they missed the savings threshold, actually generated dissavings, but we're not going to subtract that in any way. We just simply stop at what the maximum total positive savings was. Next slide, please. So with that, I know we are already 10 minutes over time. Jessica, I will hand it back to you. And again, of course, Ian and I are happy to follow up, and we'll try and get the materials out as soon as we can so that they're in your hands with any of the updates or corrections that Ian mentioned during his portion of the presentation.
Great. Thank you so much, Ian and Nate. We really appreciate the thoroughness of that. As mentioned, this will be recorded and available on CRISP's learning system, and we'll also put the updated or finalized slides also on that website. You guys will get an email when it is posted. I believe we answered most of the questions. Thanks, Will, for that in the chat. There are a couple that we are going to follow up with directly. However, feel free to email us if there are additional questions. And again, we'll make sure to answer those offline as well. So that's it. Thank you guys. I really appreciate it. And sorry for going over, but again, I think the detail was greatly needed and appreciated. Bye all.
Thank you.